One advantage of robotic surgery is as compared to a mini thoracotomy approach. In a mini thoracotomy, you have a keyhole view of the intrathoracic structures and the heart. With robotics, I'm completely immersed into the chest. It's like being in a dome or whatever, and I can look to the left, to the right, up and down. I see all the structures.
Welcome to Imperfect Heart, a place for you to join me, Jeff Holden, in conversations, discussions, and dialogue about our hearts and the impact myocardial bridges have on them. We'll talk with healthcare professionals, those in related fields that support our condition, and others just like us with stories of their myocardial bridge experiences. It's my intention for this content to inform, educate, entertain, and even motivate or inspire you in your personal journey on dealing with a myocardial bridge. Most importantly is to have you leave each episode with hope, knowing you're not alone and that what you're experiencing is real. I want to share a little bit about our guest this episode as he completes the 3-part series with David Vollmer's Journey. He's a world-renowned cardiac surgeon and a pioneer in robotic heart surgery. With over 1,000 robotic heart surgeries under his belt, he has revolutionized the field. He's been instrumental in establishing robotic heart programs at prestigious institutions worldwide, including Innsbruck Medical University, Austria, the University of Maryland, the University of Pittsburgh Medical Center, UPMC, the Cleveland Clinic, and the Cleveland Clinic Abu Dhabi. He has published over 300 papers, speaks around the globe, and is involved in multiple professional organizations. One of his most significant accomplishments is performing the first ever robotic quadruple bypass surgery. This groundbreaking procedure demonstrates the precision and effectiveness of robotic surgery in complex cardiac procedures. Beyond his surgical expertise, he's a leader in minimally invasive cardiac surgery and has now added robotic myocardial bridge unroofing to his expertise. He's held key positions in major medical societies and continues to shape the future of the field. Dr. Johannes Bonatti is currently a cardiac surgeon at the University of Pittsburgh Medical Center Heart and Vascular Institute and professor of cardiothoracic surgery at the University of Pittsburgh. What he's going to share with us today in this 3rd episode of David's Journey is something every myocardial bridge unroofing candidate should be certain to listen to or watch, as the video is exemplary to the unroofing procedure. It's my privilege and pleasure to be able to introduce him to the Imperfect Heart community. Dr. Bonatti, it's my privilege to welcome you to Imperfect Heart.
Thank you very much for having me here.
Boy, we are so excited about the conversation today. We're also joined once again by David Vollmer, whose surgery we'll be referencing in this episode. David, welcome back.
Hey, thanks, Jeff. Looking forward to this.
And just prior to hitting the record button, we were talking about this is probably and confirmed the first time that we've had a cardiac surgeon on with not only a patient, but another recipient of the similar surgery. So this is going to be a wonderful conversation.
This is definitely unique for me as well. A first, if you wish.
To get a first out of a surgeon, that's a big deal. So we're excited.
Of course, yes.
Dr. Bonatti, this is the 3rd part of a 3-part series, and it's our first that we've ever done this where we've had the patient process all 3 steps. And we started with David's story and how he's doing post-surgery now and what caused him to recognize the need for the surgery. Then we had the incredible privilege of speaking with Dr. Fowler, who walked us through the provocative testing, which to date, in a little over a year of programs, we have not been able to get a very, very good and articulate interventional cardiologist to explain the provocative test, even though we see a lot of it on the Facebook page. We talk about it a lot, surgeons talk about it a lot. And so he did an incredible job of not only discussing and demonstrating the need for the provocative test, but also gave us some of David's tests so that we could see what it actually looked like to the interventional cardiologist and what they present to you as the cardiac surgeon to know what's going on. Now we have you're the third and final step of this trilogy of episodes where this is where all that testing, all the symptoms, and everything really meets its final destination, and that is through, in David's case, robotic surgery.
Mhm.
Could you tell us, maybe set the stage of what brought you to the point of saying, okay, David, we are going to perform surgery?
It was definitely the provocative testing that made me take the final decision. Okay. The first things we look at usually are an angiogram or a coronary CT scan with the myocardial bridge, but we would really like to see proof of the functional impact of those bridges.
And as one of the leading robotic cardiac surgeons, I'm going to say probably in the world, yes?
I'm part of the small group of, internationally connected surgeons that do that surgery.
You made the decision that his situation was one that was capable of being remedied by robotic surgery. He didn't need the sternotomy.
Yes. So I had done sternotomy myocardial bridges before, and my focus in robotic surgery was coronary bypass surgery from the very beginning. And at some point, I thought, hey, we are doing bypass surgery here. If a patient shows up with a myocardial bridge and is otherwise suited, why not offering this in robotic, totally endoscopic, as we call it, fashion? And I went for that.
To date, how many of these have you done as the unroofing procedure?
So, as the unroofing procedure, my experience is, to be honest, still limited with less than 10. But all those cases went very well, and I'm very confident that we can offer this to many more patients.
And on the flip side of that, for coronary bypass surgeries, I know that that's going to have probably another zero or two behind it than 10.
Um, yeah. So my overall experience with robotic surgeries is more than 1,000. Okay, and 2/3 of those were coronary bypass surgeries. The rest are mitral valve repairs and replacements, closures of atrial septal defects, myxoma resections, some electrophysiology procedures. Most recently, also parts of an left ventricular assist device implantation. So, but I think the bridge is really a very elegant solution to the problem because, and I think the audience should be aware of that it's the advantage of robotics is that you do this through ports only, not even a mini thoracotomy. So
Yes.
this traumatic approach to that operation.
And David, you would attest you healed relatively quickly from the actual surgery itself, correct?
Yeah, I'm almost 3 months post-op, and I'm back to 100% physical activity that I was doing, pre-surgery.
And for those of us that had the sternotomy, 3 months post-op, we're just starting to get back to what could be considered normal. And it's still a process because you have to gradually work yourself back. Dr. Bonatti, in performing the surgery, there are a variety of different ways that other doctors can do it. You're performing on a still heart, correct?
I did procedures so far on the still heart, yes, under cardioplegia, as we call it. Okay. My preference for this comes from the fact that splitting, unroofing a myocardial bridge is really delicate work, okay? Where you also have the right ventricle close by, you have a lot of fat with veins above the myocardial bridge that can bleed. And I just feel more comfortable doing this procedure when the heart is really still and I have a quiet local operative field.
I know a lot of patients get very concerned about somebody stopping their heart. Could you maybe walk us through the procedure on that and the to maybe give them some security and comfort knowing it's okay. This isn't a very uncommon experience. We know how to do it.
Sure. I have to maybe say also, I'm also doing some procedures on the beating heart. Okay, I do bypass surgery on the beating heart if the patient is suited for that, best suited for that. But to stop the heart, you have to have a few prerequisites. The patient needs to be put on the heart-lung machine, cardiopulmonary bypass, as we call it. This is a pump, that circulates the whole body volume while we are working on the stopped heart. Okay, the blood is taken from the right heart with large tubes, goes into a reservoir, is oxygenated, okay, with oxygen essentially insufflated into the blood. CO2 is also taken out, and then a very strong pump sends it back into a major vessel. In open heart surgery, in sternotomy heart surgery, usually the aorta. In less invasive surgery, robotic surgery, into the femoral artery.
So by doing so, when it's less invasive on a still heart, it's almost a little bit easier because you don't have everything opened up.
Yes. Let me maybe go back to the question how we stop the heart then. So first of all, the patient needs to be heparinized. So blood thinning therapy is injected so that the blood doesn't clot when it is sent through all these tubes. And once we have adequate, what we call ACT levels, we start the pump, and the heart-lung machine takes over the circulation. To stop the heart, then, it is important that we interrupt the blood flow to the coronary arteries. That's why we put a clamp on the ascending aorta and then inject a potassium-rich solution into the aortic root. That's what makes the heart stop.
Oh, I don't think I ever knew how it stopped it.
Yes, so that's how this is done. And the heart tolerates cardioplegia, again, stopping for about 3 hours very nicely. 3 to 4 hours, we get a little nervous.
Okay. And how long was David's surgery?
So we had a little bit more than 1 hour of cardiac arrest, which is absolutely well tolerated, right, David? Your heart.
Yeah, I didn't feel a thing.
Yeah.
He seems to be doing okay. So whatever the resting time was, he's just an hour younger now.
Yes. Okay. Now again, so of course, I understand that our patients out there may be scared of that, but really for us as heart surgeons and for heart surgery teams, the cardioplegia is we can call it a routine process.
Which is great to hear.
Yes.
So you get to the heart, you've used the provocative test to identify where you need to go.
Mm-hmm.
You're now there with the robotic tools, and I know we have a special presentation, but let's walk through it first, and then we can get there. Is everything already mapped out for you? Do you already know pretty much where you need to go with the tools inside the chest cavity?
Yes. So the approach to the inside of the chest is through what we call ports, metal tubes that are inserted between the ribs, okay? And those tubes are docked to the robotic arms, and then robotic instruments and the robotic camera are inserted. That's how we approach that. And concerning orientation, it's a pretty standard approach of these ports. The one for the camera goes in more or less in the middle of the chest. It's usually the fourth or fifth intercostal space, okay? And the right and the left instrument port are 4 finger width of the camera port. That is pretty standard. And when you go in there, usually you have the left ventricle contained in the pericardial sac and a little bit of fat above right in front of you. And I was very much used to that view through the experience in coronary bypass surgery. So, and identifying the LAD, for example, is something you have to learn a little bit. You have to open the pericardial sac, of course, to get there. But I would call also that nothing very special for us anymore. We are now used to that approach. We use that one on a very broad basis.
Is there a reason that you might say no to a patient for robotic surgery?
Mm-hmm. Yes. So some prerequisites. Redo operations are something where we are not so excited at this point. I've done some, but even in open surgery, going through these adhesions, through all the scars, makes it very hard, okay? Not a contraindication, but difficult. Patients with very severe lung disease might not tolerate the single lung ventilation. So the anesthesiologist inserts a special breathing tube for these operations, a so-called double lumen tube or regular tube with a bronchial blocker, as we call it. And so for me to have good access to the pericardial sac and the contained heart, the left lung needs to be dropped, deflated. Is of course reinflated after the surgery, but patients with really severe lung disease might not tolerate that. That's why we also in David did a lung function test, and he had super values, everything above 100% predicted, so he was extremely well suited for the operation. Another difficulty for us might be the presence of severe atherosclerosis on the aortoiliac level, because the cannulation for the heart-lung machine is done in the groin, and we pump the blood from the groin upstream. You can imagine if there's a lot of plaque on the femoral iliac or arteries or the aorta, we could pump plaque into the brain. So we have some workarounds for that, but that might be an issue for candidacy for robotic surgery as well.
Now that we've set the stage for the opportunity, would you walk us through the steps once the patient is in the operating room? And, if this is a good opportunity now to actually show us.
Yeah, I will.
That might even be
my great pleasure. I had a chat with David this morning, whether he would still be okay that we show that. But yeah, you are well on board, right, David? And
100%. I'm super excited to see this.
What we did, okay?
And so what we'll actually be seeing is a video of the robotic process inside the cavity of David's body.
Sure. Let us start. Does this work for you? Do you see everything?
Yes, everything looks great.
All right. Okay. Maybe a definition again. So the procedure in robotic surgeon's term is called robotic, totally endoscopic unroofing of an LAD myocardial bridge. Okay. And so if we have a look at our operating room, we have the luxury here of using a hybrid operating room for those procedures. We also use it for robotic coronary bypass surgery. So you have a usual surgery environment. You see all the instruments that we need in addition. You see the heart-lung machine here. I will come to that a little later. A lot of other devices, the anesthesia setup here with transesophageal echocardiography, OR lights, of course, and especially here also, it's also a cath lab, okay? This is a combination between an operating room and a cath lab. We call that hybrid OR, and ours here is a robotic hybrid operating room. That's the patient cart and the robotic arms already docked to the patient. David, that's you, okay? And but you can appreciate that the robot is covered with sterile drapes. That's very important, of course. And this patient cart has 4 arms, okay? Now, I sit behind this console, as we call it. It is, by the way, I think I can name the type of robot we are using. It's the classic DaVinci robot, which we use in its 4th iteration. A 5th generation is soon coming up. I look into a binocular, as you see here. Do you see the arrow, by the way?
Yes, we do.
Okay. I have masters, as we call them, or joysticks, if you wish. My arms are leaning on these pads here. I have a small control unit here on which I can control things like the electrocautery level, a few things that I can control from here as well. Early on, the OR team had to do these functions. Now I can control that from here. I also have foot pedals. The yellow and the blue ones here control the electrocautery for cutting tissue. And with this pedal here, that's a clutch between control of the robotic instruments and the robotic camera. Yeah, so that's the console. You see me here looking into the binocular. It's I must say that if you look into such a robot console for the first time, this is just amazing. At least I felt that when I was first sitting behind that. You enter the chest, a bodily cavity, and you have a view like, say, looking into, call it a cathedral or a big dome or whatever. You have a beautiful 3D HD view into the chest.
And if I understand correctly, it's 10x. It's like a 10 times.
10 times magnification. You see the 3 ports here, okay? By the way, we insufflate CO2 here to get more space inside the chest. And we dock, as we call it, the robotic arms to this metal piece on the robotic ports. Okay, we hear a sound blip, and then we know that the robot, the computer of the robot, has recognized the port. Yeah? So, and for port insertion, I mentioned it is very important that the anesthesiologist drops the left lung. And after insertion of the first port, we insufflate the CO2, we get more space, and can insert the other ports safely as well.
And Dr. Bonatti, for the benefit of the naive listener or observer, by using the CO2, what that does, it inflates the chest cavity, correct?
Exactly. We do that at a pressure of 8 millimeters of mercury. That inflates the chest, and I have enough space to work in there. So what you see here is the insertion of the robotic camera. Again, this is a 3D HD camera, digital camera, of course. In the back, we have already a look into the thoracic cavity and a port here. It is very important that the team at the table, we call it the patient side assistant and the scrub tech, all have a good view on what is going on as well. Okay? And there is also speaker communication between me, who sits behind the console looking into the binocular. Okay, then there needs to be a microphone and a speaker at the robotic device so that we have good communication. All right. So again, the heart lung machine, our pump that we are using, it's usually on the patient's right end. Just let's recap the principle. So we have the heart with a venous side and an arterial side. The left heart chamber here, the right heart chamber. Deoxygenated blood without oxygen, comes from all body areas into the right atrium and then into the right ventricle. With the heart lung machine, with cardiopulmonary bypass, we take that venous blood off, put it into a reservoir. Yeah, the venous blood, oxygen is insufflated and makes the blood bright red again. Arterial blood is then, with a very strong pump that can pump 5 liters per minute, pumped back into the ascending aorta. And then it goes into the whole body and also into the heart. Yeah, that's the support. And that one is slowly started until it circulates all the blood volume. Next step, we do that in less invasive surgery through the groin. And you see that quite long a tube is going in to the right heart here, okay, and into the big veins. This is for drainage of the dark blue deoxygenated blood. We as surgeons had to learn from the interventional cardiologist a little bit here how to gently introduce these cannulae. So we put in the venous one first, and you see here the arterial one. Let me also show you that. That one is also inserted over what we call guide wire into the femoral artery, okay? Now, let's recap how we stop the heart. We are now under, and the cannulae that I just showed are connected to the tubing of the extracorporeal circulation. We are on full support, okay? So everything can be taken over by this pump here. And then we can put a clamp here across the ascending aorta. The blood flow is still going into the body, okay? All organs are nicely perfused except for the heart, okay? There is no blood going into the coronary arteries anymore. And what we do then is we infuse potassium-rich solution, so-called cardioplegia, into the coronary arteries, and that gives us a flat line on the EKG asystole, if you wish.
Mm-hmm.
Yeah? So if we want to do that in robotic endoscopic unroofing of a myocardial bridge, we do not clamp the ascending aorta, but we use instead a balloon, okay, which is inflated here, okay? This is the catheter that goes through the side arm of the perfusion cannula in the groin, is positioned under transesophageal echocardiography, has the balloon here at the end, has several pressure lines. We measure the balloon pressure, we measure the aortic root pressure, and here is the infusion piece for the cardioplegia. You can see here antegrade cardioplegia, and the cardioplegia solution, the potassium solution, comes all the way from the groin through this whole catheter into the aortic root. Okay, that's original picture, the balloon that we used in David's operation. The PA is testing it for leakages, make sure then that all the air comes out of the balloon. We then pushed this catheter up under TEE, transesophageal echocardiography guidance, again with a guide wire. The guide wire has to go up just above the aortic valve, and once we are there, we position the catheter and connect it to all the pressure lines and cardioplegia line that I showed you before. Mm-hmm. Good. So this now comes the point, we go on pump, and my assistant, Dr. Hess here, inflates the balloon. I position it properly just above the aortic valve. He injects, we measure the pressure in the balloon, then give a shot of adenosine. Okay, you know what adenosine is, okay, from the testing that you have undergone. Adenosine in this setting immediately stops the heart so that it doesn't eject anymore, and then the potassium solution follows. And we get cardiac arrest, cardio silence, if you wish. I think we are coming close to what we then definitely did, let's go here, just the last look. Again, this is what we see on the echo. This is the balloon inflated here, and this is the aortic root with the aortic valve. And we see the injection of adenosine like a snowstorm there, and then the cardioplegia comes in. You see here now insertion of our robotic instruments. We have seen the camera before. We have to always have a good camera view. Here's the right instrument, here's the left instrument. And what is very important in robotic surgery, the surgeon must never lose his view on both instruments, okay? That's what we learn, to always follow with the camera that we see the tip of both instruments all the time. Shall we go for the splitting of the bridge now, for the unroofing, or are there any other thoughts at this point?
So the purpose of maintaining visual sight of those two pieces of the robotic arm are because if you're not aware of where it's at, something could happen. It may
Exactly, yes.
cause damage. Okay.
That's exactly the reason. So you must not lose the view of an instrument inside the chest because you wouldn't know what it's doing.
Yes.
Maybe for our patients out there, this machine is a robot, yes, but it's not an autonomous robot. It's always under the control of the surgeon who controls these instruments with the masters, with the joysticks from the console. Good. Okay, so we open the pericardial sac, okay, and the apex of the heart comes into view. We do this with a. This is the LAD here, and I mark the LAD with a clip, as you see here. And we start, first of all, to divide the fat that usually covers the myocardial bridge. And you see here we have accessed the LAD in David's case here, and this is the upper edge of the myocardial bridge. And this is very fine work. Very, very gently you go underneath the bridge and split it with these robotic scissors. They are called pod scissors. And what you also see is a ruler, right, on that. This is 5 millimeters. And you can appreciate how thick that bridge was, 2 to 3 millimeters. And underneath we have the LAD, and we split a length of 5 centimeters here.
So I have to ask, in some of the presentations I've seen done, you all use a visual tape measure, so to speak.
Yes.
And it just seems so traditional with all the technology we have that you use something that is so basic.
That's, by the way, something I'm sure that can be integrated relatively easily. You have that on the iPhone even, right? That you
Yes.
can measure distances, okay? Thanks for that suggestion. I will carry it forward to the appropriate people. But you are right. I think that would be a very nice aspect if you had a quick electronic way to measure that distance. Yes, but in that case, I brought a ruler in and measured it by hand or by robot, if you wish. Yeah.
And the portion that we see that's a little variegated, it's obviously not smooth. That's the material that you've moved. That's the muscle tissue that you've opened up.
Muscle tissue is exactly here, okay? And remember, in the provocative testing, David, you had a little bit of spasm at the lower end of the myocardial bridge, okay? That's what Dr. Fowler described. And see, you see how thick it was most prominent at the lower end here, okay? Again, as I said, so this is 3 millimeters here. I think it was almost 3 millimeters in thickness.
And that would be also indicative if that's the part of the LAD that was getting the most compressed, it would explain why maybe there was some of that vasospasm and or endothelial dysfunction in that portion.
Absolutely. And what is also interesting to me, also in coronary bypass surgery, if we sometimes see myocardial breaches or myocardium coverage of coronary arteries on the back wall of the heart. Underneath such a breach, the coronary artery is usually completely free of atherosclerosis. Okay, has been discussed many times what the reason for that is. Probably some mechanical restraint that prevents the atherosclerosis process to proceed there. But also underneath, David's, your vessel was completely healthy. Yeah.
So, David, as you're looking at this, knowing that that's your heart, how do you feel as you look at it?
It's surreal.
Okay.
Yeah, because it's seeing the technology that was used in all of those steps. I had no idea until right now. So this is, me seeing this for the first time, and it's insane. I mean, it's super excited. I can't wait to show my family this video.
Okay, good. And it is important also, I mean, one advantage of robotic surgery is as compared to a mini thoracotomy approach, okay? In a mini thoracotomy, you have a keyhole view of the intrathoracic structures and the heart. You appreciate here also with robotics, I'm completely immersed into the chest, okay? It's like being in a dome or whatever, and I can look to the left, to the right, up and down. I see all the structures. And some people say, yeah, you are sitting a few meters away from me. Where are you? I think I'm, yes, away a little bit from the patient, but virtually closer than anyone can be. And
I don't think you could be any closer from the visual of what we're looking at, which
yeah,
is the same thing you see in your viewfinder.
yeah,
That's
okay.
amazing.
And the important thing is, I mean, this was all done through these 4 holes, okay, as compared to the midline sternotomy or as compared to a mini thoracotomy, which is usually also more that length, probably.
Mm-hmm.
And this is, by the way, the chest tube that we need after this surgery to drain the rest of air and blood that is collected inside the chest. Comes out usually after 2 or 3 days.
Now, that chest tube looks very small by comparison to the sternotomy chest tubes, where there's actually 2, one under each side of the chest. And you
Yes.
look much more robust. That's amazingly small.
One chest tube, the sternotomy ones usually come out here. It's mostly a mediastinal drain here in the front and a pleural drain going from here all the way down to the pleural cavity.
Yeah, that looks much less uncomfortable than the other process.
Yeah, that's what I wanted to show you.
That is amazing, Dr. Bonatti. For so many people who are concerned or fearful, and I know people get a little bit queasy sometimes, but I don't think there's anything there that's showing us any reason to be concerned or, even overly messy. You're inside. There's not a whole lot of blood because the heart's not beating.
Yeah.
Boy, that's just an amazing, amazing video. So post-surgery now, David goes to ICU. The patient typically would go to ICU for recovery and then back into a hospital room. What are some of the concerns and or potential risks with robotic surgery?
Okay, good. So in any type of surgery, bleeding can happen. Okay. If it is so, the bleeding from the veins in that fat patch above the myocardial breach, that can be relatively nasty, and it can be controlled, yeah, with clips or electrocautery. But one advantage of doing it with cardioplegia is that you don't have that while unroofing the breach. What you can do is, instead of using a scalpel or scissors to split the fat here, is use the electrocautery that burns the small vessels right away. But usually that bleeding can be nicely controlled with the methods I just mentioned or with hemostatic agents. Okay, there's several different ones. One is called Tacosil. We have also something that is called Arista. That's a sort of it's made from potato. It's potato powder. Okay, a powder, potato powder that you spray on these diffusely bleeding sites, and it would stop with applying that Arista. That's manageable. If you, and that can happen also in open surgery. I don't know whether this was, I'm sure it was discussed with you. The right ventricle is closed, okay? And sometimes in these operations, you enter the right ventricle, okay? And you can, with a stitch, control that. That's why I also prefer to do it on the stopped heart, because doing that with the heart fully beating may be possible, but makes you very nervous, I think, if that happens. Only in cases where we had a major problem. Yeah, I mean, we mentioned earlier that if you lose an instrument and, God forbid, enter the right heart wall, okay, that's a situation where the heart-lung machine is your big friend, because then go on pump again and fix the problem robotically.
Mm-hmm.
Should you drift into something that is really not controllable anymore, then you convert to a sternotomy and fix the problem that way.
And you say the good news is you are aware of A, the potential, and B, the solution.
Exactly.
In worst case scenarios.
Exactly. I mean, and we discuss this with our patients, of course, and that applies for any less invasive surgery, be it the heart, be it the lung, be it anything in the abdomen. The less invasive surgeon has to tell the patient that if things become very difficult, it's best not to try to fight this through, but open and do the most standard procedure available.
And then, David, if I can ask you, post-surgery, ICU into your hospital room. We wish it was a hotel room, not a hospital room, right?
At UPMC, the patient rooms are hotel rooms.
I teed you up for that, Dr. Bonatti. I teed you up for that.
Yes.
David, how did you feel after that experience? You know, if you can recall the fresh experience just out of surgery.
Well, the best experience was when Dr. Bonatti was shaking me in the ICU, waking me up and telling me how good it went, and that, you know, everything looked really well. The surgery went really good, and he was very pleased. Like, his enthusiasm really made it better for me, because, you know, the support I got from him on that really helped my recovery, because I was reassured many times on the big success that it was. And my wife appreciated those words too, as she was, you know, sitting beside me, and I was just wanting to get an ice cube in my mouth because I was so dry.
Yeah,
I understand.
Well, and Dr. Bonatti, your enthusiasm in the presentation and just your willingness to do this it's effusive. It's reassuring, and it's extremely exciting for me, and I hope for everybody else as they watch, to say, this is a surgeon that really cares about the process and is excited about the process. And so it's amazing. What are some of the downside, or I should say downstream risks? I know occasionally there is some pericarditis, maybe it could happen with any of the surgeries, but it seems maybe it's a little more prolific in the robotic surgeries.
Yeah. So also in the bypass surgeries where we place a Lima bypass to the LAD, okay, there is a little bit of a higher incidence in pericarditis, okay? We see that on the EKG with some ST segment changes in all leads, essentially. There's no real scientific explanation for that, but it happens. Usually that's treated with either ibuprofen or colchicine. Those are the drugs of choice. It's not at all a dangerous problem, but it takes a few days to weeks to resolve. Mm-hmm. Coming to the post-operative things that we have once in a while, a longer chest tube drainage, okay, that some patients just have more fluid collection inside the chest as a reaction to the operation, and that would keep the chest tube a little longer. Pneumothorax, if air is collected there, same thing, the chest tube would stay a little longer for that. And with any heart surgery, most commonly in robotic mitral valve surgery is atrial fibrillation, okay, that appears again as a reaction to the surgical process, but usually can be treated nicely with medication also.
And that's one that we are most familiar with,
Mm-hmm.
a condition of the process. This is a question I've asked of all the doctors that we've had on the program. Is it, in your opinion, possible that myocardial bridges could be responsible for sudden cardiac arrest?
Yes, I think it can be responsible for it. Rare though.
Mm-hmm.
I mean, if we compare it to the common incidence of myocardial bridges, I think the proportion of sudden death is rather low. Hard to create data here.
Understood, yeah.
Because there are other reasons, more common reasons.
Well, and what we struggle with is it's pretty well known that the myocardial bridge, where the artery enters the heart, there always tends to be some narrowing of the artery, whether it's through occlusion or if it's just from compression of the heart over time, but it's narrower going in.
Mm-hmm.
And if there is atherosclerosis as a result of plaque buildup over time from that particular condition, and that patient passes and it looks like a widowmaker was blocked, the LAD was clogged and over, so we see the situation. But in fact, if he didn't have the myocardial bridge, it may not have been like that.
Yes, really agree. Yeah.
So that's going to lead to the next question. If and this is not an if, this is, we hope other surgeons do see this, because you did such an exemplary job of showing us the condition in the cavity, but we still get dismissed. I would say we probably have half the cardiology community still doesn't believe that myocardial bridges are symptomatic.
Mm-hmm.
What would you say to those doctors, the medical community, about myocardial bridges, that in fact, yes, they are real and we have to address them?
I would point out to them the huge importance of provocative testing, okay? That it's not only the artery, the LAD that you see on the angiogram, with the squeezing, with the systolic compression, and with the milking phenomenon, not only the breach that you see on the CT, but it's the tests that Dr. Fowler has so nicely explained. I would tell them, send the patient to Dr. Fowler, let him do these tests, and then we have more clarity about the importance of the bridge.
And I do appreciate that we're starting to see centers of excellence communicating with each other. And Yale has a study going for INOCA. And of course, Stanford has the myocardial bridge research team. UPMC is now entering into the repair and diagnostics of myocardial bridges, amongst some other big systems. So we're really excited to see that, and the fact that now people will have an access point in the greater, Pittsburgh, but certainly in the state of Pennsylvania and the surrounding areas, wherever is most convenient, they have a place to go. I want to touch just a little bit on the DaVinci machine, because there is some concern about some of the machines, and now we're going into another iteration of that machine. I think it was the SI was the first one with the stabilizer to work on the beating heart. Then the XI came along, no stabilizer, and they changed some things for the better in the grand scheme of it all. And then now with the newest machine, is there anything that is uniquely different that allows you to do something different as we look at the technology of the machine moving forward?
Yeah. I think one of the features of the 5th generation DaVinci, it will be called, or it is called the DV5, okay? The company has integrated force feedback or tactile feedback I would think that specifically the work you have seen today, that might be something where tactile feedback might help. I grew up without tactile feedback, and I'm so used to it that I test drove the DV5. First sight, I didn't feel much difference, but when I did my first total endoscopic bypass surgeries, the part where I really struggled a little bit without the tactile feedback was splitting the fat above the coronary artery. Okay, that I had to learn virtually or with visual sensation. And I think if you have tactile feedback from the very beginning in these new machines, might help for the operation we are discussing today.
Sure, I can see that. You have that haptic feel of pressure
Yes,
or tension to give you the understanding of what it is that you're dealing with in terms of either density or.
exactly. Want to point out though that tactile feedbacks is something, the lack of tactile feedback is sometimes used as an argument against robotics. You can learn that, okay? You learn how to use your visual sense to compensate very well for the lack of tactile feedback. If you think about the old BlackBerry that had tactile feedback and everyone uses an iPhone that's, I think, which has no tactile feedback for the keys. So that's an appropriate comparison, I
I
think.
think that's a perfect comparison because we all said, "Oh, I hate it, I hate it, I hate it. I can't use this iPhone thing. It's terrible." And look where we are today. Before we wrap, I have a question for you. People like to know their surgeons are human. You present so very, very comfortably. I don't even question, but what is it you do to relax? You have such a high stress job. You're working on people's hearts every day. What does Dr. Bonatti do in his downtime?
Okay, so coming from Austria, I grew up on skis and I love skiing. Okay, I went last weekend here at the small ski area in Seven Springs. We had super snow and it worked very well. In summer, I mountain bike, I play tennis. Concerning reading, I like to read into history, philosophy, and at times astronomy, cosmology. That's what I like.
Well, you're welcome to join us in the Sierras this year. It looks like we're going to have some snow. So anytime you come out, just let us know.
Will do. Okay, thank you for the invite.
Dr. Bonatti, at the University of Pittsburgh Medical Center, you guys are really moving forward now into a proactive approach for myocardial bridges. And I thank you on behalf of the audience for that. How does one go about getting a hold of you to learn a little bit more about what the center is offering, as well as learn more about their particular conditions?
A very easy way is to Google minimally invasive heart surgery at UPMC. Then you will land at the UPMC Heart and Vascular Institute website. A phone number, which I have, by the way, put on the presentation at the beginning on the title slide, is 412-648-6200, option 7.
Okay, and I will put this in the show notes for the episode as well. David, this is 3 episodes. So we started with you. We went to Dr. Fowler to learn about how they got to the next decision to work on you. And we just had an incredible presentation from Dr. Bonatti. Any thoughts for the audience before we wrap?
Well, I just want to say thanks to Dr. Bonatti and to you, Jeff, and to Dr. Fowler for all being willing to get this story out and to show people that, just because your doctor doesn't say, says no and dismisses it, there's these centers of excellence. Like Dr. Bonatti and Dr. Fowler did Zoom calls with me. I had some basic testing done and we were able to communicate, over Zoom being, 300 miles apart. And he made me feel very comfortable that it was going to be worth the journey then to go out there. And that was one of the most reassuring things because I was being dismissed at the local cardiologist like everyone else does. And then as I presented more information, they're like, we don't know how to help you. We don't know what to do. And as soon as I got a hold of Dr. Bonatti, he was on time. Even the one day he was early. So that showed me that this team and his team that surrounds him, all the girls in the office and the other doctors that work with him, really provided literally every answer that I had a question to, and it made it really easy to go through the process. So it's These guys are exceptional in what they do from the customer service side and all the way through to the technicality of doing the unroofing.
Well, and now on the outside of it, you're 3 months out, and how are you feeling for those who have not heard the first episode yet?
Oh, I'm feeling great. I mean, I'm back to do full workouts. Dr. Bonatti and I talked this morning. I'm getting my heart rate up into the 120s, and pushing hard and no issues. I feel amazing. There's been no symptomatic, or post-symptomatic that I had pre-surgery. There's none of that anymore.
And if I'm not mistaken, you did have a little bit of AFib that now seems to be under control.
I did. And I did a lot of blood testing, and it was more of a mineral deficiency. And once we got that fine-tuned, it's been almost 4 weeks now with no AFib or anything else.
That's great to hear. Well, Dr. Bonatti, this has been a first for us, first for me, a first for the three of us. I cannot thank you enough from the very bottom of my imperfect heart. And I know I speak for the audience when I say that what you have just given us is going to instill the confidence in them to continue to pursue a solution to the symptoms that they've got. And I hope it allows a lot of the other cardiologists, the cardiology community, the medical care community to recognize that there is a procedure. We now have the steps you take, from the provocative testing to the actual procedure of the unroofing procedure, to know that this is a condition that can be remedied and quality of life can be restored. So for what you guys are doing at UPMC, again, thank you so much, and I appreciate you for taking the time with us today.
Let me thank you both very much for the kind invitation to this podcast. I enjoyed the conversation very, very much. I learned a lot as well, and all the best to you and your initiative and to the patients and colleagues you're helping. Thank you very much.
Thank you. Thank you for listening to Imperfect Heart. It's my hope that this information helped in some way to improve your situation or will help you better understand this condition. More importantly, that it gives you hope through stories that there is help and you most certainly are not alone. If you've been diagnosed with a myocardial bridge, please be sure to join the private Facebook group, Myocardial Bridge Support Group. For more information about our program or to reach me directly, visit the website, myimperfectheart.com. If you like what you heard today, please give a positive review, thumbs up, high five, or whatever your app likes. And be sure to share with everyone important to you so they understand what it is you're dealing with. Please subscribe as well. Welcome each day with gratitude and positivity. The views and opinions expressed in this program are solely those of the host and the guest and are not intended to provide, nor are they a suitable substitute for, professional care by a doctor, therapist, mental health professional, or other qualified medical professional. Imperfect Heart is a production of Hear Me Now Studio.